Okay, everybody. I can see quite a few people are still drifting back in. I have to confess I'm having a really bad day with QR codes today. They're just not my friend. I've discovered that the one that's in the on the back cover of your workbook with the attendance certificate for the evaluation, that actually links back to a former event that we did, not to this one. So please just ignore that, and I'll email everybody after the event with the correct QR code so you can do your evaluation then. So my apologies. Obviously technology is playing up for me today. But now I'll hand you over to Belinda.
Thank you, that one. Yeah. All right, welcome back everybody. So we'll make a start on the next part of the day, moving on to cardiology, looking at the assessment of ischemic heart disease risk. Obviously can be a little bit of a minefield from a GP perspective, navigating which tests to order, when to follow up, and when to refer to specialists, and even the funding of some of those investigations has obviously got a little bit more difficult. So that'll be really great to cover. So please welcome Dr. Sankasara. Thank you.
Hi, thank you, Belinda. Good morning, everyone, and thank you very much for making time on a Saturday morning for education, so highly appreciate your presence here. Look, I've been given a very broad topic to cover, and I'll just try to stick to the time I've been provided and try to be useful to all of you. So just a bit about myself. I'm Deepen Sankasara. I'm one of the interventional cardiologists, and I've been working at General Hospital for nearly a year and a half now. Been here in Australia for about 16 years after my med school in India, and I've done my basic and advanced training here and all my residency days here. So had a wonderful time learning things in the system here. Did my fellowship at Royal Perth Hospital, and then I went over to the UK and did another year of training in complex interventions, and that's what my primary soul and interest is. Next, is this the one I'm assuming? Yes. So I will be talking about, so I was given a topic of cardiac investigations, but I thought maybe I'll focus briefly on simple stuff and then just move on towards the coronary imaging and coronary cardiovascular disease. I have no disclosures. Having said that, I have used some of the slides from my mentor and a good colleague, Dr. Idaid, who is an interventional cardiologist and imaging specialist at Fiona Stanley Hospital, who is also a research lead there as well. So objectives for today's talk. Trying to keep it simple again, so I'll talk about common investigations in cardiology, which I'm sure you know a lot about, so I won't dwell too much into it. Then talk a bit about preventative cardiology, what it means in the community care at primary care level, and also then assessment of cardiovascular disease and what is the current evidence and why we do certain things. So look, I'm pretty sure you all know what are the basic steps of how we are doing the risk assessment. So I'm just trying to give a bit more insight into why we do it, what is the evidence, and why it's quite exciting phase in the last 5 years where we are leading to more advanced technology and imaging and tools that's available to us for early identification of coronary artery disease and reduce cardiovascular health disease risk burden. So we all know ECG is the gateway to cardiology. Everyone who comes to clinic with some sort of remotely sounding cardiac symptoms have to have an ECG. And that's what we all do. I will not be talking about this, but we all know that it can detect various arrhythmias, ischemia, various pathologies from a cardiac perspective, and it's a fast, inexpensive, and universally available test in the community. Having said that, it's got its own limitation. It's just a snapshot of that present moment. So patient may or may not have symptoms when they come for assessment, and the ECG may be normal and obviously they're non-diagnostic unless it's an acute setting or in hospital. So then obviously all of you are aware of various ambulatory ECG monitoring modalities, and that's kind of a next step of assessment for mostly rhythm-related problems. And there are various modalities we use, be it a Holter monitor, or an extended Holter or sort of patch-based devices. The one picture I put on the top right is something called Cardia 6-lead device that's used very commonly, very useful tool. And the bottom picture is of an implantable loop recorder, which is kind of a longer-term monitoring device that can be implanted under the skin for patients with certain indications. What are the main indications? Mainly, it's all to do with arrhythmia, so patients with pre-syncope, syncope, palpitations, which are concerning or quite symptomatic or limiting for the patients. And also, quite a lot of times we use it for post-stroke detection of paroxysmal atrial fibrillation, because then it changes the management of patients to reduce their future stroke risk. They all have their own limitations. So the diagnostic yield of Holter monitoring is generally low, but that's the guideline from the Medicare and MBS perspective, that they all have to have Holter before they have any form of extended monitoring to be reimbursed. So that's one of the first key steps. Also, a lot of these tests rely on self-reporting of symptoms. So again, patients have to be able to confirm that they were having similar symptoms at the time of, if we have recorded any arrhythmias. Just a brief slide, which should be available on the website for review, but basically each of the device, how it works, and what's the best clinical indication or scenario where you would consider using it, and what are the key advantages of each of these device. And as I said, mainly Holter is a key. First, extended monitoring, that's followed by event monitoring of some sort. Then we can sort of consider doing an implantable loop recorder. Two key reasons we would use them would be recurrent syncope and atrial fibrillation. Those are the two main indications we use it for. And then if patients have very infrequent but concerning symptoms that's difficult to detect, but they don't meet MBS criteria for loop recorder, then we do recommend cardiac device to a lot of these patients. And most of the time, this is mainly to reassure patients that they do not have any life-threatening arrhythmias. And we're happy to talk to them. The advantage of cardiac device or similar device, again, I have no shares in this device company, but the main advantage of this is patients own this device. It costs cheap, $200 to $300. And then they can record on their own with their mobile phone. They can use it whenever it's needed. It's very mobile, so you just put it in your pocket and keep it with you all the time. So very useful device. I thought I'll put this slide up because we do get quite a few of these referrals that we see in patients who have valvular heart disease. And kind of this is just a basic idea of how we surveil these patients based on the severity of their valvular heart disease. And when we say surveillance, it's mainly how frequently they need echocardiogram. So generally, based on all the international guidelines and consensus reports, if anyone has mild valvular disease, and I only put up aortic stenosis and mitral regurgitation because they are the two common ones and two more significant ones that we deal with all the time. I mean, clinically significant ones. So aortic stenosis and mitral, both of them. So if it's a mild severity, then generally 3 to 5 years is adequate, unless obviously there is a change in symptoms. So these are all guidelines. Whenever there is a change in symptoms, we always have to reassess severity. In terms of moderate, generally it's 1 to 2 years. We do like to keep closer eye, yearly echo surveillance. Patients feel more confident and reassured if they have a bit more frequent reviewing of their valvular disease. And certainly if they have severe pathology, then either they are already being considered for intervention for those particular valvular disease, or if they are asymptomatic or on borderline, then generally they would have 6 to 12 monthly, more like 6 monthly surveillance imaging. I'm not going to touch upon a lot of other imaging modalities that we use. There are transesophageal echocardiogram, MRI, CTs. We can use a lot of different multimodality imaging, like sort of to have a bit more comprehensive assessment. Especially we are working towards the sort of intervention for that particular valvular heart disease. But there are options available, and generally those things are then discussed in clinic, and then we just go through them on individual basis. So I'll I'm trying to come straight to my, sort of favorite topic, and also the topic that probably you are all kind of more interested in listening about coronary artery disease. So I'll start with more of a preventative risk assessment kind of a side. So who should be screened? So about 2 years ago, new heart foundation guidelines came through, and they've given a lot of sort of indications about which are the key patients that you need to be keeping a close eye on and screening early for early detection. So generally, the focus is on asymptomatic, intermediate, and high-risk patients. So that's the one for screening for cardiovascular disease. When it comes to symptomatic patients, it's a very different approach. So this one's for asymptomatic patients. So the current guidelines say all people who are age 45 to 79 years, younger if they are First Nations or Indigenous, people with diabetes, again, start screening at younger age. And if they are clinically determined high-risk groups based on their comorbidities, then have early assessment or screening for these patients. So one of the key tools, so there are a lot of, I'm sure you are all aware of, and a lot of you use these as well, a lot of risk calculators or tools available digitally for these kind of scenarios. So one of the common ones that's currently endorsed by the Heart Foundation is the Australian Cardiovascular Risk Calculator. It's specifically based on the data from our local population. It does take into consideration our indigenous population as well. And there are a couple of other key things. One of them is the postcode, which kind of is a very crude indicator of their socioeconomic status. And more importantly, it also has a capacity to reclassify patients based on their either their ethnicity or their other comorbidities, whether they can be downgraded or upgraded in terms of their cardiovascular risks. So I find it very useful, and I use it quite commonly whenever I have been referred a patient for sort of preventative or risk assessment. And what it tells us is basically you put in all these numbers and details and yes and no's, and it just gives you an idea what's their estimated 5-year risk of cardiovascular event or hospitalization. There are a few other sort of tools that are available, and I would say we could consider using this for specific populations. So this one is an American risk calculator which focuses on 10-year risk, and it has similar sort of input points, but also has a section for African American population and other ethnicities. And similarly, the European score is called HeartScore or HeartScore 2. And again, this is also for estimating 10-year risk of cardiovascular event. And this one has an interesting way of classifying things in terms of low, moderate, high risk, and very high risk. And these risks are based on their country of origin. So this is not their comorbidities. So in this risk, what you do is you basically identify what country the patient is from, go to that risk category, and then put in all the other things. So we have a lot of, obviously, European settlers and population here. So it might be worth considering these kind of calculators tailored to those population. All right, so what should screening include? So us and a lot of other practices, including GP practices, run cardiovascular risk assessment clinic or heart health clinic, or there are a lot of other fancy names we use. And basically all of these clinics, what we do is we are looking at their traditional cardiovascular risk factors, measure their blood pressure, certain blood tests for, again, their cardiovascular risk factors, weight, BMI, and an ECG. These are the sort of things we measure in the clinic. Important one or of note is the lipoprotein A, especially useful in younger people and people who have family history of premature coronary artery disease. And general recommendation is you generally only measure it once in their lifetime because it is not meant to change. We have had a few patients that the LP little a has changed a little bit, but it generally is of no consequence. It just basically is telling you whether it is low or high, and then it just gives a risk of arterial and venous thrombosis risk in the future. We do not know how to treat it yet, so it's just one of an indicator or diagnostic tool at the moment, rather than something that we can tailor treatment to. So other one then the key one we sort of nowadays have been doing, and a lot of you have been requesting, is the coronary artery calcium score. So who should have it and why we should do it? So it's a useful tool in predicting cardiovascular risk in asymptomatic non-diabetic individuals. So a lot of the data, or all the data for this calcium scoring, is coming from a big registry called MESA registry. And in that registry, they excluded symptomatic patients and they excluded diabetics. So generally, it should be reserved for asymptomatic non-diabetic patients. Again, in the registry itself, they did not have patients less than 45 years of age. So when we do it in younger population, diabetic, indigenous population, we don't exactly know how to sort of extract that information. So we recommend using other sort of clinical indicators to assess their risk. And why we do it? Look, in plain words, is to tell patients that you should be taking aspirin and/or statins. That's the plain reason we do it. And I'll come to that why these are important. So this is just sort of a plain boring slide of atherosclerosis and how the plaque progresses. But importantly, it shows where we detect the calcium score in the scheme of things. So in the first, the type 1 is sort of a normal vessel, so it's left alone. It's just basically got a bit of a lipoprotein deposits and inflammatory response beginning there. But after that, the macrophage foam cell starts to accumulate. At that point, there is no plaque, so calcium score would be 0. Then there is a pre-atheroma phase when there is a pool of extracellular lipid that starts to accumulate around the vessel. And that's the soft plaque we all talk about. Then it sort of encroaches into the vessel, into the intima, and there's a core of extracellular lipid still there, which is expanding. But this is the time where sort of microcalcification starts to develop. And beyond that, it progresses into fibrous thickening, more calcium deposits, and then advanced calcification related to the plaque. And our aim is to detect patients when they are at type 4 or type 5 phase, where we can either identify microcalcification or early low-grade calcification, so that we can sort of direct the patient that, hey, you got high risk or you got moderate risk. In your 5 years or 10 years lifetime, you're going to probably have 10% risk of having cardiovascular event. So when we put these numbers to the patient, they already are, if they're coming to you for risk assessment, they've already taken that first step of taking ownership of their cardiac health. So when we tell them, okay, now you come to me, you got now 10% risk, they will generally take advice on board at an early stage and hopefully start to modify their behavior, their lifestyle, and go on a pharmacotherapy in appropriate settings. So how we interpret the calcium scoring? So these are the different scoring categories that we use. And generally, basically, if the calcium score is less than 100, the risk is low to very low. And after that, the risk progressively increases as the calcium score goes high. Score more than 400, certainly very high risk. And at that point, we should be already thinking of either doing some sort of a functional assessment for ischemia or subclinical ischemia, or referral to a specialist for early assessment in case there is an underlying asymptomatic disease that this addresses. A key point here to remember is once a high score is detected, so anything more than 100 is detected, generally a repeat calcium scoring does not or should not alter the approach to patient's management, because we've already given an advice at that point that you should be now taking aspirin and this is your target LDL. So after that, if it's 100 or 500 or 800, that advice remains the same in asymptomatic patients. So generally the recommendation, because we get a lot of patients who ask like, oh, when should I have my repeat test again? Now my score is 700. Should I repeat in next year? And I said, it's not needed. You already are in a high risk category. So let's just now focus on your reducing your risk of cardiac event. This slide, I put it up to basically just demonstrate the importance of aspirin and statins in patients who have coronary artery calcification at an early stage. And the area where I think we should focus on is the bottom half, where it's showing number needed to treat. So we can see that calcium score more than 100, number needed to treat to reduce one coronary event over 5 years, with aspirin is 173, and with statin is 24. It's quite remarkable number actually. 1 in 24 people may not have a heart attack in 5 years if you start them on statin. That's remarkable. And that's may not again. And again, all of this should come with a caveat that they should all have been recommended appropriate lifestyle changes and risk factor modification recommendations as well. So again, this slide is about, again, re-emphasizing the point, like how often we should do it. And this is mainly about if someone's calcium score is 0, then should we do it or not? And the answer is yes, but not too soon. We should probably wait about 5 years, and that's where we start to get benefit, because over 5 years, we can see from this graph that generally it's a very interesting way to put it, a warranty of calcium score of 0. That's just really nice way to put it things. But what it is saying is, at 5 years mark, if someone had a calcium score of 0, their risk of having a calcium score of more than 100 is low, very, very low. And the bottom sort of schematic is showing that event rate is very low in the first 5 years, 0.7%. And then after that, about 72% of these patients in this particular study had zero calcium score, and their event rate continued to be lower. Whereas those who had higher calcium score at 5-year mark, they had about 3 to 4% times higher risk of cardiovascular event. So who shouldn't get calcium score test? So in my opinion, and the guideline, it's not my opinion that counts, I'll be honest. So the guidelines recommend that patients with chest pain should not have calcium score, mainly because we may miss soft obstructive plaque. When I say soft plaque, is that first initial phases where there is more of a lipid pool and lipid-driven plaque, and they shouldn't have calcium score because we won't see calcium. Pregnant women, known calcium score of more than 100, as I mentioned before, known coronary artery disease or stents, because they're already now classified as high risk once you have a cardiac event. And then if they just want to know whether the treatment is working or not, we get a lot of this, I'm sure you all get them as well, and there's no indication. It's purely based on whether your calcium score is more than 100 or not. If it's less than 100, wait. There are gray zones. If it's like 50 to 100 and they are sitting on the fence like, well, I don't want to take statins yet, there's no strong evidence that I need to start statin because it's still less than 100 the score, then you can say, okay, let's check in 2 to 3 years, and then that may just prompt the patients for statin. But remember that the whole point of calcium score testing is to recommend aspirin and statin to appropriate patients. All right, I think I already might be running late. I've got a lot of slides to get through, but now I'll talk about CT coronary angiogram and why we do it. We all know we do it in what settings and things like that. I'm just going to briefly talk about what's the evidence and why it is a very useful tool in current day and age. So we know that cardiovascular disease is one of the key cause of mortality, in fact, number 1 cause of mortality in both Western and developing world. Chest pain is one of the most common ED presentations, and traditional risk factors and tools may not be all the time sufficient to personalize preventative therapy. I put this slide up to just demonstrate that current evidence is showing that the CTCA has a very high sensitivity and also specificity for potentially obstructive or functionally significant coronary artery disease when compared to other functional modalities of ischemia studies. So when I say that, to put it in plain terms, stress echo perfusion scan versus CT coronary angiogram. CTCA beats them in majority of cases. Having said that, the functional testing still have a role, especially in asymptomatic patients First of all, the asymptomatic patients shouldn't have the CT cornea angiogram, but they do sometimes end up having CTCA. And then a lot of patients say, oh, actually, I didn't have chest pain, it was something muscular. And now we got a CTCA which is abnormal, and then we're not sure what to make out of it. So in these scenarios, especially if it's a functionally significant or prognostically significant coronary artery disease, then functional testing still has a role to look for subclinical ischemia. So this is just one of the pictures from one of my patients who had a CT cornea angiogram with a nice 3D looking image, who had chest pain, and then he went on to have an angiogram procedure which showed quite severely stenotic disease in proximal LAD, and we can see how beautifully it correlates with the CT imaging. I must say, look, it's not always the case. It is the CTCA's main role is its sensitivity. So its negative predictive value is very high. If it shows normal coronary arteries, it is normal coronary arteries. When it shows stenosis or plaque, its specificity is about 80 to 85%. So generally it correlates in right patients, but when there is calcific plaque, then it sometimes overestimates or very rarely underestimates the stenosis. So we just have to be cautious in this scenario and put again the risk factors and symptoms and clinical situation into perspective. So this is again just talking about sensitivity and specificity when compared, when it's not compared to, but just take, these are the patients who basically had CTCA and then went on to have coronary angiogram, and it's just showing that how accurate they are and how, especially if the coronary arteries are normal. And again, there are different, this is more of a technical slide where there are different kinds of scanners depending on how fast they can scan. And basically, more than 64 detectors means they can scan faster, they can get more high quality images or high resolution imaging. This was a trial, again, I'll just be very brief, more than 3,500 patients with stable chest pain and intermediate pretest probability went on to have CTCA or invasive coronary angiogram. And what it shows is basically there is no difference in major cardiovascular event at 3.5 years. However, the procedural risk was higher, obviously, in invasive procedure group. So what it is trying to say is if they have stable angina, you could still do coronary artery disease, because majority of the time if they do not have prognostic disease, and when I say prognostic disease, what it means is left main disease, proximal LAD disease, or proximal disease in CIRC and RCA, which are technically not prognostic, but then they may be relevant if they go on to have MI. But when we talk about prognosis, generally left main and proximal LAD disease. So if they don't have prognostic disease, then generally it doesn't alter their outcome or rate of major adverse event over 3.5 years from this study. Now, we don't just do CTCA to assess for amount of stenosis or obstructive disease. The current generations of CT scanners are really good at identifying plaque morphology and what we call as certain plaque, high-risk plaque characteristics. And again, the plaque may not be intraluminal, it may be extraluminal, but that can also give us a lot of information, especially if you're looking for high-risk plaque features or microcalcifications. And from studies, we know that mild stenosis on CT scan is not benign. People with diffuse mild coronary artery disease have more risk of cardiovascular event compared to normal coronary artery disease at any point. Because once people start to get atherosclerosis, they will always have an event. And in fact, we also know that it's not necessarily the calcific plaque that has a plaque rupture. It's in fact the non-obstructive soft plaque that ends up having an MI with a plaque rupture event. So that's why it's important to identify and treat them with aspirin and statin and maybe other risk-modifying agents. This was a registry looking at symptomatic stable patients and looking at the risk of MACE based on their plaque burden. And essentially, if more plaque they had more risk of adverse event. Again, I might be running out of time very shortly, so I'll try to keep it brief. Another slide to again stress upon the point that more plaque, more risk. This is one of the key studies we always refer back to or fall back to whenever we talk about CT coronary angiogram, Scott Hart study. So this was a landmark study. Essentially what they did was they collected 5,000 plus patients who had stable chest pain symptoms and randomized them to having CTCA or invasive coronary angiogram. And then there were lots and lots of sub-studies to look at patients' characteristics, demographics, and a lot of other clinical risk factors. And this is one of them is basically saying is if people had a CT coronary angiogram compared to standard care where they may not have angiogram because the symptoms are not critical, but they still have established coronary artery disease on CT coronary angiogram when we perform it, then their outcome over 5 years is much better. And it's to do with how better care we provide to the patients and how attentive patients are to their own health. And again, it comes down to aspirin and statin. This is just a slide, again, more of a technical slide, which is looking at certain high-risk features I was talking about. And when we see these in modern scanners, we always recommend to patients to look after themselves better, change their diet, change their lifestyles, address the risk factors. And this is basically one of the other studies looking at this plaque morphology with statins. And basically statin slows progression of coronary plaque volume. So these are the guys who had CTCA over a period of time at certain intervals after going on statin therapy. But key thing is it did not affect progression towards high-grade stenosis. It just reduces the progression. And statin increased plaque calcification. So again, a lot of patients with calcium score of 80 or 100, they go on statin, and some of them ask for a repeat scan, and their score is 300, and say, oh, I went on statin, now my score is higher. And two things. One, you probably didn't need calcium scoring, and two, yes, it is expected to go high as statin converts those sort of early lipid-rich plaque into microcalcification or calcification. Again, important of lifestyle changes on plaque composition is cannot be said more. Again, I'm trying to skim through things because Wendy's going to hassle me very soon. So investigation of chest pain, basically which chest to choose. The guidelines are sort of divided, but it's coming to a consensus where eventually CTCA will become the first-line test. American and the European models from the 3 or 4 year old guidelines are showing basically if they have chest pain and stable disease, assess with a tool, and then if they come to intermediate or high risk, then send them for CTCA. Low risk, investigate otherwise or treat their comorbidities. Whereas the NICE guidelines for the British, they go on to have CTCA for everyone upfront. Chest pain, CTCA. And what it has shown is basically, I'll just skim through this, but in the NICE model or BIT model, it is showing that there is significant increase in CTCA numbers, but reduction in invasive coronary angiogram or other functional testing. And why? Because a lot of times we are saying, oh, you don't have obstructive disease, just modify risk factors. So then they don't need as many invasive coronary angiogram. Where we do the functional testing, then we may get false positive, and then they go on to have angiogram that was otherwise not required. This is a slide from Abdul's paper based on his research that he did, and basically he's put up these guidelines about assessment of stable chest pain. And how CTCA is basically should be the first line investigation for majority of patients with chest pain, or stable chest pain, I should say. Again, I might just skim this, but basically first line CTCA reduces the downstream testing and invasive coronary angiogram, something similar to what the NICE guidelines or British data has shown. Again, CTCA leads to greater bidirectional change in medical therapy, and it kind of helps us giving right treatment to the right patient cohort. So to summarize, CTCA is quite sensitive for excluding coronary artery disease with a high negative predictive value. It detects non-obstructive plaque and guides preventative therapy. It's rapid test, non-invasive, reproducible, and it enhances patients' understanding of their risk via visual results. So generally, if they have high calcium, I just show them the scan and say, hey, look. And they're generally more keen to adapt to treatment. It has its own limitation, obviously. The accuracy is low when there is higher the calcium, lower the accuracy. It requires low heart rate, so it needs patients to have medications pre-procedure, pre-CT scan. Some of the patients don't tolerate beta blockers or evaporating very well. There is a risk of contrast nephropathy or allergic reaction, and there may be incidental findings that may trigger over-investigations. But sometimes we found, lung nodules and few other things that have also been useful. So these are just basic tips. I think I've covered all of these into the talk, but important one is it can be only done by every 5 years, even if requested by a specialist. And Medicare reimbursement is currently just with specialist referral. General cost for CTs is anywhere between $800 to $1,000 and about $500 to $550 of rebate from Medicare. We should avoid it if they had prior stents. Not necessarily too. There is a newer technology where it uses photon counting CT scanner, which can look through the stents better. But again, I'm not going to advertise any particular company or scanner. But there are technologies that we can tailor it to patient's requirement. And yeah, it's important to discuss preventative therapy. Just brief slides, which I'm very sure you all know of. What are the current targets for lipid lowering, for blood pressure, for HbA1c? It's essentially the cardiovascular risk profile. So in summary, you guys all play a very important role in cardiovascular risk reduction in the community. There are tools available for risk stratification, and early referral for symptomatic patients is critical, and CTC is increasingly becoming a key investigation. Open for any questions.
Thank you very much. I was just going to ask about cardiac MRIs, please, and when you would use those.
So cardiac MRI current role is for congenital heart disease. Then look, myocarditis has been one of the newer indication where it's now getting reimbursement for the patients. Then we use it for certain valvular pathologies, or endocarditis sometimes use it for. And importantly, pulmonary hypertension or looking for shunts, so QP, QS. So those are kind of the main things. So the main ones are congenital heart disease and myocarditis. Those are the two key ones that I would use. Then certain HOCM patients we use it. Then we individualize after that. There are arrhythmias where we can use it, like someone with ARVD, arrhythmogenic right ventricular dysplasia. So if patient's having an RVA or TVT proven on some imaging or having syncope related to them, then we can use those ones with Medicare reimbursement. But majority of the MRI are still unfortunately patient funded. So it has to be special indication, which is reimbursed by the MBS at the moment.
Thanks, Stephen. You mentioned that a score of less than 100 AU. You said individualize. So who are the patients we should, go for statins or?
Yeah, so look, so generally what my approach would be to put them in that risk calculator, identify who are the intermediate or high risk patients. Those ones I would start or recommend treatment early. If they are low risk, they're young people with no comorbidities, no medications. Generally, I would say, okay, change your lifestyle. You are already heading towards having coronary artery disease. Let's reevaluate in 5 years. But generally, if they have intermediate or high risk, so already on hypertensive treatment, diabetics, obese patients, or indigenous patients, those are the people I would say early recommendation. Yeah.
I have a question. The patient with atrial fibrillation, is the CTCA of any benefit in investigating chest pain in atrial fibrillation?
So yes and no. So with the CTCA, there sometimes may be artifacts, but there are scanners. As I said, it also depends on the quality of the scanner. So certain fast scanners, and we can scan cardiac, like heart in one cycle. So there are certain settings we can do where we can just scan the whole heart in one beat. And if we apply those settings, we can still scan patients with atrial fibrillation as long as their heart rate is less than 60. So yes, there is role. We can still do CTCA for patients with atrial fibrillation.
I would like to know the role of myocardial perfusion scan, please.
Yeah, so generally MPS nowadays I reserve for patients who can't have CTCA for whatever all those reasons. They had already 1 in 5 years, or they have kidney disease, or they already have high calcium score. then my approach is generally I go for functional testing. So then the rule is if they can run on a treadmill, I generally try to get stress echocardiogram because it has higher sensitivity and specificity. But if they can't do exercise, then MTS. That's my general approach. Because echo, we also get other information because with the stress echo, we get baseline cardiac function assessment, valvular pathology. So we do get a bit more information because a lot of these patients are also vague or I've got shortness of breath and we are looking for ischemia or cardiovascular disease. So for me, CTCA, can't have CTCA, go on to have either a stress echo if they can do exercise. If they can't, then then I would recommend for myocardial perfusion. That's my approach, and it's purely based on convenience and specificity and sensitivity of the test.
Depend. For CTCA, they are less accurate when you have coronary calcification,
Yes.
and a lot of elderly people have it. Are there certain amount of coronary calcification when you say the result of CTCA is less reliable?
So as I said, higher the calcification, less reliabilities. But people with high calcium score will more likely have obstructive coronary artery disease. So CTCA may not be reliable to accurately give the degree of stenosis, but those guys will more likely have functionally limiting coronary artery disease. So in those ones, I would generally go for, so old elderly patients, smoker, I haven't put smoking there surprisingly, my bad, I'm so sorry. Smokers, elderly people with diabetes or poorly controlled diabetes, they are likely to have high calcium score and less accurate CTCA results.
Brilliant. All right, thank you so much.
All right.
Really appreciate it.
Thank you very much.
All right, so next we've got Dr. Cheng Lu from Western Respiratory. Today he's going to be talking to us primarily about sleep apnea, but we owe Cheng and his team for bringing a whole new level of respiratory services to Joondalup in terms of essentially really a tertiary level of care in terms of the investigations and things that can be offered that wasn't the case in the past. So yeah, please welcome Cheng. Thank you.
What they do, I move the button using my finger? Or? Oh, yes, the big green button. Oh, the big green button. Okay, thank you for having me here in the Men's Health Masterclass. So, men have a very important role in our society. Men work, build, explore, and protect. Yeah, it's a very important role. And when men lose those sense of vision, then they become very depressed. We see that all the time in people we know, in our patients. But life is not always easy. Life has lots of problems. And yeah, there are lots of challenges, including health challenges affecting our men. But we cannot help everything. There's a lot of problems, but we can do something. We can do something to make the lives and health of our men better. And today I'll be talking about sleep apnea and how it affects men differently than women, and some of the diagnostic tools for sleep apnea, and when you diagnose them, what you can do about it. So why it matters? Sleep apnea is very common, especially in middle-aged and elderly men. Yeah? And a lot of cases remain undiagnosed. And it is a major driver of morbidity and also cardiovascular risk. Yeah, so yeah, I'll probably add a slide to Deepan. He did not put in smoking, and he has put in sleep apnea. Yeah. It's it's very much undiagnosed because when you get men in your clinic, especially when they come by themselves, they tend to underplay their symptoms. You see it all the time when you ask about sleep apnea questions. Yeah? When is the man alone, you ask them, do you snore? No. Are you tired? No. And then, yeah? But when their wife is there, then they say, oh yeah, you snore loud like a train, you know? Hey, you fell asleep watching TV yesterday, yeah? So the history become more accurate when their wife is there, partner is there. That's why married men live longer, yeah? So just be aware, the men tend to underplay their symptoms, so a lot of them remain undiagnosed. Because we see them on the other end of the spectrum, we see them after they get treatment, A lot of them, they say, hey, yeah, I am more alert during the day. Yeah, more energy, I did sleep better. Told you so, yeah? So they tend to play down their symptoms a lot, yeah? So you just have to just know that that's a behavior of men. And because of the sleep apnea symptoms, it put a lot of burden on our society, yeah? So their work productivity reduced because of their symptoms. They are also at risk of cardiovascular disease, heart attack, stroke, atrial fibrillation, hypertension, yeah? So a lot of burden to our community and healthcare. So this talk, I'll go on to why sleep apnea affects men differently than women. Women tend to have a different set of symptoms with sleep apnea. They tend to have more insomnia, whereas men tend to have the typically more of the typical symptoms like loud snoring, tiredness, sleepiness, though they tend to underplay the symptoms. And men also at higher risk of cardiovascular disease from sleep apnea. And there are the reasons for that, which I'll go into more detail in the subsequent slides. So why men are higher risk than women? Men tend to have wider neck, yeah? Wider neck, not just the width, but also going inside. So the airway is smaller, yeah? So there's more soft tissue in the neck. Because of that, they are at higher risk of upper airway collapse, yeah? And a lot of men also like to take exogenous testosterone, yeah, even though it may affect their cause infertility, but they love to a lot of them love to take it. It makes their arm bigger. They may even look good when they are going topless, but it put them at higher risk of sleep apnea because it increases your muscle bulk. So your muscle bulk in your neck also increase, which is okay during daytime, but during nighttime when you sleep, the muscle relax, muscle tone relax, airway collapse. Yeah. And men also like to drink alcohol, and some take sedative medication are more common in men. Yeah? So they are at higher risk of sleep apnea. I put there Asian men. Asian men are at higher risk of sleep apnea. I'll go into more detail later. Yeah? So in a bit more detail, so the neck circumference, men larger neck circumference, inside full of soft tissue. Yeah? Whereas the woman neck circumference tends to be smaller, and men are high risk because of the fat pattern. Men tend to put more adipose tissue from waist up, whereas women tend to be more peripheral. Yeah. Hormone, the female hormone tends to protect, it maintain the muscle tone. The estrogen maintain muscle tone in the upper airway. The progesterone is a respiratory stimulant. Yeah? So women, at least until menopause, women are more protected. Yeah. After menopause, then they know how men feels like. Yeah. Men have been suffering. The airway length for men is also longer. Yeah. My wife is only slightly shorter than me, but my neck is probably 25% longer. I compare to her neck next to each other. You can compare that with your husband or wife later. Yeah. But the longer neck, it's just like engineering. When it's longer, it's more collapsible. Yeah. So men with the longer neck, just anatomically, there are more area where it can collapse. Yeah. And the arousal threshold, by that I mean how quickly the body awake to disturbance. Women tend to have lower arousal threshold, which means that they tend to wake up earlier. So that's why their sleep apnea tend to be more disruptive, more insomnia. Whereas men don't awake, you need to, you shake them, your patient is shake them, they don't wake up. Yeah. So the arousal threshold for men is higher, which also put them at higher risk. Yeah, because their oxygen level can drop very significantly before they wake up. Yeah, so just remember that. Yeah. So a bit more cartoon. So the one at the top right-hand corner is your normal upper airway. So when you sleep, there's still enough room for the air to go in and out. Yeah. The second one is when there's a partial obstruction. When you sleep, your muscle tone in your palate, in your tongue relax, and the airway can narrow. So that causes snoring, it causes partial obstruction. Sometimes it completely collapses, yeah? and it can be completely collapsed for some time. Your oxygen level can drop, leading to hypoxemia. It can cause arousals. And when the airway collapses, it stresses the body, so the sympathetic tone increase. And that can happen multiple times at night. Yeah. Yeah. So risk factors, again, I put there male gender. I did not have to put it in the past, but male gender because they have to be biological male, not identify as male. Huh? Yeah. Asian, but Asian at higher risk. By Asian, I mean the East Asian, like myself, Chinese, Korean, Japanese. The East Asian facial feature is very narrow, especially the anterior-posterior dimension, very narrow. So, so East Asian are at higher risk of sleep apnea, even with normal BMI. In fact, BMI is not a good predictor for East Asian. Yeah? It's more their upper airway anatomy, the upper airway appearance. So that's why Asian cannot put on weight. Yeah? If you replace the tiny dim sum dumpling with Big Mac, you knock out a lot of Chinese men with sleep apnea. Yeah? Yeah? So, yeah. So next risk, BMI. BMI is good for most people except Asian. Just be careful that if you have grumpy Asian men, even though they appear normal BMI, they may have sleep apnea. Yeah? Or they have low libido, you know, they're tired, cannot focus, maybe sleep apnea. So just remember that for Asian men. Yeah? As mentioned before, the neck circumference, yeah, men neck circumference bigger, they tend to have more alcohol and the testosterone. Yeah? Now this one is your what to look for. Yeah, what to look. You look at the size when they walk in. In particular for Asian men, look at their upper airway or their facial anatomy. Yeah, if they have a receded chin, especially that one, the thyromental angle. The wider that angle is, the higher the risk of sleep apnea, especially in Asian. Yeah? Asian, don't rely on BMI. Yeah? Just see how their appearance like and get them to open their mouth. If they have very high Malampati score, then they are at high risk of sleep apnea. In children, they have tonsils. Most adults don't have big tonsils anymore. Then we can see their Malampati score. Yeah? So what symptoms you get? We all know the typical symptoms of people with sleep apnea. Snoring, yeah, their bed partner said they wake up choking, they're tired during the day, yeah, men tend to play down the symptoms, nah, no problem, I'm fine, you know. Then you ask their wife, their partner, yeah. But there's also atypical symptom, you know. If they're irritable, you know, is this ADHD or not, you know? Their poor concentration, low libido, you know, they wake up with morning headache, they grind their teeth. So those are the other atypical symptoms that may suggest sleep apnea. So something that you can think about. Yeah. So other clues to sleep apnea, if they have difficult to treat hypertension. Yeah. If they need 2 or 3 more antihypertensives, still hard to control. And especially if you do a 24-hour blood pressure monitor, they have a non-dipping pattern. Yeah? Because a sleep apnea tends to cause a non-dipping blood pressure pattern. Yeah? The normal blood pressure over 24 hours, when you sleep at night, it drops around 10-15%. So there's a normal dipping pattern. Yeah? But because sleep apnea causes repetitive arousal, repetitive stimulus of the sympathetic nervous system, they can lose that nocturnal normal dipping. Yeah? So if you have a non-dipping blood pressure pattern, it may be from sleep apnea. Yeah? And that is associated with higher cardiovascular risk because at night when you sleep is when the cardiovascular system relaxes. It's supposed to sleep as well. But when it's always stressed, that non-dipping pattern has high association with cardiovascular disease, heart attack, stroke, hypertension, AF. Yeah, moving on to AF. If you have patient with atrial fibrillation, sleep apnea is very highly associated with AF recurrence, and even after ablations, the risk of failure of cardiac ablation if they have untreated sleep apnea, it's very high. Yeah? When you treat the sleep apnea, it half the risk of recurrence. Even in mild sleep apnea, it increased your rate of recurrence of AF by around 15%. Yeah? Moderate sleep apnea around twice, and severe sleep apnea sometimes more than 3 times risk of AF recurrence. Yeah? And you treat them, roughly it half the risk of recurrence. With stroke, sleep apnea predisposed to stroke, both ischemic stroke and hemorrhagic stroke. And it's also bidirectional in the sense that if you have a stroke, especially if it affects your upper airway, yeah, you lost your upper airway muscle tone, you're also at higher risk of sleep apnea. So it's a bidirectional relationship. Diabetes as well is bidirectional. If you're a patient with a very difficult to control blood sugar, and they have symptoms that suggest sleep apnea, rather than cranking up their insulin, maybe send them for sleep study as well. Yeah? Because when you reduce the sympathetic stress to the body, you may find that the blood sugar a bit easier to be controlled. Yeah? And there's also secondary cause of depression. Sleep apnea can worsen mental health like depression and erectile dysfunction. Yeah? Some semi-objective score, how you quantify the severity. The Epworth Sleepiness Score is a questionnaire that you can use to gauge how sleepy your patient is. Yeah? So less than 8 is considered as normal, but you also need to see which item they score higher in, because not all of them are similar. Yeah? If they score high, say sitting and talking to someone, or question 8 in the car while stopped for a few minutes in traffic, then it's a red flag. Yeah? Then, hey, I need to pay more attention to my patient. Yeah? So yeah, not all the items carry the same weight, even though we tend to just look at it as the final score. There's also the stop bank questionnaire, which you can use to screen sleep apnea. Yeah. So you suspect your patient has sleep apnea, yeah, even though they like to deny it. What to do next? Yeah. The way to confirm your suspicion, sleep apnea, is to do a sleep study. The current gold standard is an in-lab sleep study. We call it level 1 sleep study, very comprehensive. It's done in the hospital. Yeah. It it's basically a direct measurement of airflow, EEG, EOG to check eye movement, EMG to check REM sleep, and also the effort, chest movement, tummy movement, and snoring. So that's a gold standard, the current gold standard now for diagnosis of sleep apnea. When you do the similar monitoring device, you do it at home, we call it a level 2 sleep study. Yeah? And below that, when you monitor less parameter, there's level 3 and level 4 sleep study. Yeah? The level 3 and level 4, they are, generally speaking, good enough if it's moderate to severe obstructive sleep apnea. Yeah? But when it is mild sleep apnea, or even mild to moderate, it can be hit and miss sometimes. And the level 3, level 4 does not really differentiate you between the rarer cause of sleep apnea, like the central sleep apnea. It's mainly for your moderate to severe obstructive sleep apnea, your typical patients. They can be pretty good. Yeah. So when you have the sleep study, then you have the report coming back, AHI, apnea hypopnea index. So what's apnea hypopnea index? Yeah? Apnea is the airway completely collapsed. Yeah? And hypopnea is when it's partially collapsed. We quantify that by at least a 30% reduction in the airflow. Yeah? And the two of them have to be at least 10 seconds long, and associated with either a 3% drop in your oxygen saturation or arousal based on your EEG. Yeah? And the apnea hypopnea event per hour is what you have the AHI, yeah? Apnea hypopnea index. So that's the level 2 sleep study. You can see the obstructive apnea, the airflow completely stopped. And there's some hypopnea, you can still see some airflow. And you can see the oxygen saturation deep down, and when the patient wake themselves up, then it recover back. Yeah? And down there is the effort belt, the chest and tummy movement. And the severity, how do we quantify the severity? The normal is less than 5, AHI less than 5, mild is between 5 and 14 AHI, moderate between 15 and 29, and severe above 30. Now, sleep medicine is a relatively new field. Yeah? It's quite a young specialty. When I was a trainee in Charlie, some of the senior consultants said they have to fight very, very intense battle with the president of the Thoracic Society, because at that time, they would still believe that sleep apnea is just like witchcraft, like nonsense. Yeah? So it was real only a few decades ago. Yeah? But now we start to recognize, hey, sleep apnea is real. It is a real thing. But there are limitations on how we measure sleep apnea. Yeah? We come up with this thing called apnea-hypopnea index. Someone pluck it out of the sky. Let's call this apnea-hypopnea index, and these are the severity. Yeah? There are weakness with the AHI. Yeah? It's not the most robust measurement of your sleep apnea severity. Yeah? Because your airway narrow collapse in an hour, 3% drop in saturation, it may still be normal, 97% drop to 94% saturation can still be normal saturation, can be counted. Yeah? So a few limitations. They do not account for the severity of the desaturation. It can be normal, still normal, or it can be normal but significantly abnormal. Yeah? Sometimes can drop to oxygen saturation of 70, sometimes can drop to 94. So AHI doesn't tell you that. Yeah? And we classify apnea-hypopnea if the event is at least 10 seconds. So sometimes can be 10.1 seconds, we call it apnea, or person may not breathe for 20, 30 seconds. So it's still counted as one apneic episode. Yeah? So it doesn't account how long the episode lasts for. And how broken the sleep is not accounted in your AHI. Yeah? And whether they have enough REM sleep, enough deep sleep, all these are not being looked into in our AHI. Yeah? So some paper, more and more we get more and more research, we find that the symptom correlation between AHI and symptoms are not the strongest. Yeah? And if in fact, there are other parameters better for the symptoms and also for cardiovascular risk. Yeah? And another limitation of AHI is it doesn't tell you, is it apnea, hypopnea from obstructive sleep apnea or from central sleep apnea? They are different, but it all coming into your figure of AHI. Yeah? So it's still work in progress, but in the coming years, you will find there are a lot of new emerging parameters, because now we start to recognize there's actually a lot of weakness. We probably, as a specialty, we made some mistake. Yeah, our first move is wrong, but now we recognize, hey, there's a problem now. Yeah, it doesn't correlate very well sometimes with cardiovascular risk compared to other parameters. Doesn't correlate particularly well with symptoms. Yeah, so there are emerging parameters which we are moving towards a more physiologically makes sense parameter. Yeah? Like, for example, hypoxic burden, how long their episodes are, and their sleep architecture metric. Yeah? Whether they have enough REM sleep, whether their REM sleep is broken, they have enough deep sleep or not, whether their deep sleep is broken. So those are the emerging parameters. So, keep an eye on this space, because in the coming years you find there will be new parameters for sleep apnea. So you have your patient, you suspected they have sleep apnea, and you prove that they have sleep apnea. So what can you do? what's the management? Yeah. So lifestyle very important, especially if they're overweight. Weight loss can help. Reduce alcohol, because alcohol is a sedative medication. It reduces your upper airway muscle tone. A patient will tell you that when they drink, their snoring is worse. Yeah? And if some sleep apnea are very positional, then you can also do positional therapy. Yeah? Now the incretin very popular, so it can be very effective for sleep apnea. If they lose like 10-15% of their body weight, it can lead to a lot of improvement in their sleep apnea. And if after the lifestyle and weight loss, the generally considered gold standard is your positive airway pressure therapy, like CPAP. Yeah, they're generally considered the gold standard for treating sleep apnea. Very effective, but there is a machine, not very sexy when you use it at night, so not very popular among young people, but very effective. Yeah. There is also the MAS. MAS stands for Mandibular Advancement Splint. If they have the smaller lower jaw, the receded lower jaw can be suitable. So tend to be more effective for mild to moderate sleep apnea patients. Tend to be more effective for those with normal BMI, female. Yeah, so female, less BMI, mild to moderate sleep apnea, a receded jaw, those patients are good candidate for your dental splint. Yeah. But even in people with severe sleep apnea, if they cannot tolerate CPAP, we still get them a dental splint because it roughly reduces the severity by half, roughly. No, not everyone. Yeah, so usually we see it as something better than nothing kind of treatment. In selected cases, your surgery can be useful. If you're very rarely you see adult patient with big tonsils, I see that probably once or twice a year. And when I see that, I'm usually very happy. I just send them to the surgeon. Yeah, so removing that can make the sleep apnea a lot better, sometimes even cure it. The maxillofacial surgery in adult patient is very seldom done. It's basically the maxillary mandibular advancement. In pediatric, it's done a lot more common. If you bring the lower jaw forward, you increase the upper airway space. It can cure the sleep apnea, but it's a very involved surgery. The planning can take more than a year and can be very costly. But it can, for selected patients, cure the sleep apnea. In patients whom you tried everything, you tried CPAP, they can't tolerate it, they're not suitable for surgery or dental splint. If they are very hypoxemic, you can prescribe them nocturnal oxygen. Yeah? So it doesn't treat the underlying cause of sleep apnea, but at least it treats some of the problem. Yeah? It can reduce their hypoxic burden. Yeah? And in some patients, you treat them, and they still come back to you, hey, doctor, I'm still tired, I'm not better, or probably only 50% better. If they are still excessively sleepy, like the FF score above 13, 14, in those patients, we can prescribe them stimulant medication. Yeah, it's one of the indications for stimulant medication. So some picture of the CPAP. Yeah, very effective, a bit cumbersome. But some people, around 10% people cannot tolerate CPAP no matter how long you try it for. Now, I put this slide here because in Australia, CPAP is not, from the government point of view, is not really, you don't need license to sell CPAP. Yeah? So if one day you tell the McDonald's CEO they probably want to sell CPAP along with their Big Mac burger, yeah. So you don't. It's not really a medical equipment. Anyone can sell CPAP, but that's why there's a lot of places selling CPAP everywhere. Majority of them are not doctors run. In fact, almost all of them are not doctors run. The place I trained was in Charlie. At that time, it was the only physician-led sleep clinic for a long time in WA. It was the only one, so I was brought up in that culture, and I do feel the patient can get better care in a physician-led clinic, yeah, because not just the assessment, the support, but we also have access to our other colleague. Yeah, we can run MDT with of ENT surgeon, our dentist for the difficult cases. Yeah, and then the treatment is guided by what's actually needed by the patient. Yeah. The commercial CPAP center, a lot of them, they're very easy to access. They're suitable for your straightforward patient. Yeah? But the key thing is that you, as a GP, we need to take charge of their management. Because very often I see patients being sent to those clinics, and when they go to see follow-up, they download their data, they give them thumb up. Hey, AHI is normal. You're good. Bye, see you next time. Remember to buy a mask. Yeah? Yeah. So if you send your patients to a commercial center, just take a mental note. You need to be the main person in charge of the sleep health of your patient. Yeah? Because majority of the commercial center, they are not doctors run clinic. So I think I'm moving on to my last slide. Plenty of time. Oh no, lots of questions. Yeah. So very important as the GP, because you are the main driver. Yeah. Because there are a lot of commercial CPAP center. When you send patient there, just remember you look at their overall health. You get a sleep study report back. Hey, do my patient really need $1,000, $2,000 CPAP machine for this mild sleep apnea? Is a mild sleep apnea actually clinically relevant? Yeah? So you need to answer that question. Otherwise, you find that your patients will be $1,000 to $2,000 poorer. Yeah? Or sometimes when you treat sleep apnea, then the treatment itself can generate central sleep apnea. We call it the treatment emergent central sleep apnea. The treatment for central sleep apnea is ASV machine. It can cost up to $6,000. Yeah? So just be careful, because I've seen a number of patients, they bought very expensive machine, which they don't actually need it. Yeah? So if you send your patients to commercial center, just take charge. Hey, your sleep apnea is very mild. You have no symptoms. Your oxygen level did not drop. Yeah? You only have snoring. Yeah? Your wife can use a earplug rather than a CPAP machine. You know? Or if they have other health conditions, say they have atrial fibrillation, a previous stroke, then yes, you need to treat it. But if it's a simple, some of them just have sleep study, very mild sleep apnea. If it's not clinically significant, you may not need to treat it with, like, for example, CPAP machine. Yeah. So that's a very important role, especially in Australia, because CPAP is not a licensed item. And when you see a patient with sleep apnea, check, make sure if they need a CPAP, make sure they're compliant with CPAP, make sure the treatment is effective, make sure it's clean, because we do see, I've seen cockroaches inside the CPAP machine. Yeah, so it can be, yeah, so just check. And if the patient is well managed, usually once a year follow-up is okay. Get them when they see you, get them to bring their own CPAP machine. Then you know the machine looks clean, it's hygienic, it's effective. Yeah, because you can get some big problem if your CPAP machine is not being maintained properly. And yeah, and the lifestyle measure, which you're all expert in. Okay, so some red flags. Yeah. If you're a sleepy driver, especially commercial driver, there's a red flag. Always have them assess the oxygen saturation. If it drops a lot, that has a higher association with cardiovascular risk compared to AHI. Yeah, and if they have arrhythmia like AF, yeah, then those are red flag for treatment. Okay, so last slide, very common. Men tend to downplay their symptoms. It is serious and associated with higher cardiovascular risk, higher risk in men than women. And think beyond snoring. If you have grumpy guy, can't concentrate well, irritable, Asian man, with a narrow upper airway, just think of sleep apnea. Treatment can be very effective, and as a GP, make sure they have the right treatment. And treatment can improve their overall health. Yeah, and their cardiovascular health. There are more evidence now on cognitive mental health with sleep apnea, and also relationship health, relationship. Yeah, stop their snoring, they don't get bashed by their bad partner. Yeah. Okay. So we do have a sleep clinic in Joondalup. Yeah, it's one of the avenue for referral. And yeah, any questions?
Thank you very much for that. You briefly touched upon sleepy drivers. I find it a real bane of my life doing driving medicals when sleep apnea is listed on the medical file. I find commercial drivers a lot easier because they're a bit more engaged with their treatment. They know their career depends on it. How do you approach private licensing medicals in patients who have a diagnosis of sleep apnea? I know it might be a bit too complex for one brief answer, but yeah, just love to know how you approach it.
Yeah, the sleepy driver is really difficult because all your patients, when they sense that you're going to put restriction on their driving, they're going to downplay their symptoms. So then you take back history, have the person involved in car, motor vehicle accidents or near-miss accidents, whether collateral history from their family members said they're sleepy. So those raise your suspicion. Yeah? And also when they're in front of you, if they have droopy eyelids, they look tired, yeah? Then it raises your suspicion. It is the responsibility of the patient to inform the Department of Transport. Yeah? So, but you can strongly encourage the patient just to notify Department of Transport that they have sleep apnea. The Department of Transport will not take their license away if their sleep apnea is controlled. Yeah? So I see it as one of the way to engage them in treatment. So a lot of people are worried that they cannot drive. When they cannot drive, in Perth, you cannot drive, you're done. You can lose your job. Yeah? So a lot of them are worried about that. Then you tell them, hey, they will not take your license away. I start them on treatment first, get the treatment better, and then I inform the Department of Transport that way. Yeah? It also has some insurance implication because, say, for example, they get into motor vehicle accident, it's someone else's fault, and if they did not declare they are moderate to severe sleep apnea, then they can have problem with the insurance. Usually when I tell this to the patient, that the Department of Transport will not take the license away, we just need some time to treat a sleep apnea, and there may be insurance implication, most of them will engage. But if you have some patients, they have snoring only, and snoring only, they are in your clinic, they are bright awake, your collateral history also confirm that, they have no accidents, no near-miss accidents, then you can probably say, hey, this person does have moderate sleep apnea but does not have symptom. Because for the driving restriction, you need those two things, moderate to severe sleep apnea plus symptoms or doctor's suspicion. Yeah? The difficult thing is the doctor's suspicion. In a lot of the private center, the private commercial center, for them to do sleep study, the patients will need to score very high on the Epworth sleepiness score. Now this is very dangerous, yeah, because it means that the person volunteered that they are very sleepy. And when they come back with moderate to severe, I think those patients put themselves at a very difficult position. Because if they get in an accident, and the lawyer look back, hey, you fill in the Epworth sleepiness score of say 14, 17, and moderate sleep apnea, those patients, I think they definitely need treatment, or they're in a very difficult position. Because you all have referred to private sleep center before. For them to access Medicare rebate, they need to score very high on Epworth sleepiness score. Yeah? But if the sleep test then come back moderate to severe, the patient is in a very difficult position. Yeah? Because legally, I think it's really hard for them to dig themselves out of of the whole. Yeah, does that answer your question? Yeah, absolutely. Yeah.
Do you think that playing a didgeridoo would improve the sleep apnea, mild sleep apnea?
Can you repeat your question again?
Playing the instrument didgeridoo, would that improve mild
Yes,
sleep
it can.
apnea?
It can for mild to moderate sleep apnea, but the problem is that you need to play the whole day. Yeah, it can. So playing some musical instrument can increase your upper airway muscle tone. So there are research about that. The problem is that you need to play the whole day. Yeah. Or you need to play for long hours. Yeah.
Just a quick one.
Coming to that, that's very interesting because there are emerging treatment for sleep apnea. And some of the emerging treatment is that they put a spray. It works on the potassium channel. It's a spray. It helps increase the muscle tone. So if they've gone through proper clinical trial, if it's successful, then you may have people who use spray for sleep apnea. Maybe good. Yeah. So, but that's the concept. Your upper airway muscle tone. Yeah. So there are some emerging treatments for sleep apnea. Some tablets, including some spray. They are not commercial yet. They're still in the clinical trials. Yeah.
Can I just quickly ask about home sleep study versus in lab, and I guess relative or absolute contraindications to the home sleep studies? So, who would be the patients that you'd send to the lab more likely than not? Because I'm just reading about obesity hyperventilation syndrome as one of the relative contraindications to home sleep study, and obviously most of our patients wants to do a home sleep study because I think it's a bit cheaper. So just wondering what your thoughts are. Thank you.
Yeah. The home sleep study, especially if it's level 3 and below, they are mostly for people you suspect have at least moderate to severe obstructive sleep apnea. If you think, hey, this person I suspect have hyperventilation, you can get clue on that on the serum bicarbonate. Yeah? The normal serum bicarbonate is 24. If it's very high, around 30, they have excess BMI, then they may have hyperventilation. So they are probably better off having either a level 2 sleep study or level 1 in an in-lab sleep study. Because we can measure the carbon dioxide level. And other thing is that if you suspect other condition, like, hey, does this person has parasomnia? Does this person have REM behavior disorder? Yeah? Or does this person have periodic limb movement with restless leg? Yeah? Then they are better off having at least a level 2 sleep study or in-lab sleep study. Yeah? And if the patients cannot keep the equipment on, then they need to do an in-lab sleep study. Some patients, they just take off everything. They go home, then you go back, we don't have any data. Yeah? So those patients are better off having the in-lab sleep study. But majority of patients, especially when you suspect they have moderate to severe obstructive sleep apnea, they can have a home-based sleep study. Yeah? The home-based sleep study varies a lot depending on the center you send to in terms of the quality. Generally speaking, if you send to a medical clinic, the quality is better, generally speaking. Yeah.
Some years ago, I think I read about a pharmacological therapy that was approved in the US with a combination of, I think it was a stimulant and something else. It never seemed to sort of go any further than that.
Yeah, the pharmacological therapy, they're still in the pipeline. They're not mainstream. They're still research phase. There's a combination of oxybutynin plus another agent, I can't remember the name now. It can reduce your AHI. Yeah, it does. But the problem is that they're still working out in terms of the side effect and then still trying to work out the subtype of patients to put those medication on. So pharmacological therapy, they are coming. I suspect in the next 5 years, you may find some pharmacological therapy for sleep apnea. But now we do have pharmacological therapy, it's weight loss medication. Yeah? Both the semaglutide and tirzepatide, they are proven to improve your sleep apnea. Yeah? There is a very big clinical trial on tirzepatide, on the SURMOUNT trial. People with severe sleep apnea, they can become either mild or no sleep apnea, yeah, when they have significant weight loss. So in some way, we have some pharmacological therapy, but for the specific pharmacological therapy for sleep apnea, it is coming, yeah, including what I mentioned, the spray, which may be coming. It looks very promising.
Can you elaborate on the position in sleep therapy?
Yeah.
And there are some advertisements on social media, I think, about a certain pillow.
Yeah. Yeah.
Does that work because it extends the neck more consistently while you sleep?
Yeah. So some patients have what we call supine predominant sleep apnea, which means that they only get sleep apnea when they're sleeping on their back. Yeah. So then you go back to your history. You you ask them, hey. Usually you ask the bed partner, hey, this person whenever sleep on the back, then this person snore and then get the elbow or everything. Then you know history-wise is compatible. Then you look at the sleep study report. Because most sleep study report can see the posture. You can see the posture in the events, apnea hypopnea in the events. If you see it correspond, they only get sleep apnea in sleeping on their back, then these are the patients suitable for your positioning therapy. They can be like a night shift device. When they lie down on their back, it gives them a buzz to prompt them to sleep on the side, better than getting an elbow or kick, can be effective. The thing is that not everyone is suitable for this treatment. Some patients, when they sleep on their side too long, they get sore neck, sore back. So you don't want to treat one problem with another problem. So for those patients, sleep repositioning is not a good choice. Yeah. So those patients you still go with either CPAP or dental splint. Yeah. But if it's good history, sleep study report compatible with supine predominant sleep apnea, and they don't get any aches and pain sleeping on their side the whole night, then those patients can get away with repositioning device. Yeah, they can have, pillow. They also a little sleep backpack. Yeah, sleep backpack. It comes out like a shark fin behind. Yeah, so when they roll, they tend to roll to their side. Yeah, so you can custom made it. Quite expensive. Sometimes I tell my patient, just go to Kmart, buy a soft backpack, put some pillow behind. Yeah, so they can be effective as well. Yeah.
My mother used to sew a cotton reel on the back of my father's pyjamas to do the same job.
One more? Yeah. I was just going to say, I tell my patients to do similar all the time. I say tennis ball, hair elastic, and just get a T-shirt or a singlet that is slightly bigger than what you would normally use, and put it in the back, and it just stops you laying on your back.
Yeah. Sometimes some patients find tennis ball not effective because it moves around. Maybe it's a baseball. Yeah. Okay, thank you so much.
Thank you very much, Cheng. All right, so it's now time to break for lunch until 1. When you do go out for lunch, just take note that our sponsors who have made today possible will be leaving after lunch. So just take a chance to go around and have a talk to them. That would be fantastic. There's also a few people who may have taken their name stickers but not signed in on the sign-in sheet. Just make sure that you do that as well during lunchtime. That would be great. Thanks, everyone.